2, 1. Please start, so we are live.
Good evening to all distinguished delegates and our eminent speaker, Dr. Yogesh Kothari, sir. I am Satish Rama Joshilkar from Zydus Medica, honored to welcome you all on this scientific digital platform called CLEARTalk. Talking about CLEARTalk is one more initiative and facet of Unite Against Dyslipidemia. As you are aware that 7 out of 10 patients are having uncontrolled LDL cholesterol, and which increases the risk of mortality in patients. And therefore, the latest update in the management of dyslipidemia, bempedoic acid, we bring you the latest updates from ACC, American College of Cardiology, which was presented in 2023. Clear outcomes, trial results. So today's eminent speaker, Dr. Yogesh Kothari, sir, is here to deliver session on CLEARTalk and clearing all our doubts on bempedoic acid. Would like to introduce sir before we start. So, sir is consultant interventional cardiologist, electrophysicist, HOD of Cardiac Sciences, Bhagwan Mahavir Jain Hospital. Dr. Kothari undertook a fellowship and training in cardiac electrophysiology and undergone various training program under KM Cherian Dr. Thomas at KM Cherian Frontier Lifeline Hospital. He has vast experience of 15 years in academic institutions, various academic institutions, and he is having proficiency in a variety of cardiac interventions. So there's a lot of expertise and training and stuff he has undertaken, and of course he's principal investigator in many international trials like IMPROVE, BRADY, Emperor Reduced and Emperor Preserved and DAPA-HF, etc. So he's also member of CSI, Indian Heart Rhythm Society, and ESC and Heart Rhythm Society. Without wasting much of our time, would like to welcome sir and hand over the session to Dr. Yogesh Kothari, sir.
Thank you very much, and thanks for Zydus for providing this opportunity. We'll not waste much time as we are slightly delayed in the schedule. Can I have the slides, please? So we all know that, there's a new kid in the block to manage dyslipidemia and manage it more effectively, because there were always gaps in the previous therapy, be it intolerance, be it achieving the lipid levels. So hence, bempedoic acid came as a good molecule for all of us to get our targets better. We all know that LDL cholesterol, the lower is better, and it's not just lower is better, it should be for longer, the low LDL levels should be achieved. And this is just a graph showing the various drugs that have come in over a period of time, and how the PCSK9 and various other trials have done and what they have done. And if you see our CETP, it has 3 trials, ezetimibe has 1 trial, fibrates have 9 trials. So that way, compared to ezetimibe, CETP inhibitors have much more trials. So each 1 millimole reduction of LDL gives more cardiovascular event reduction. And it also depends on the year in trial. And if you look at the year in trial of more than 6, the reduction in risk is almost 36%. So the longer you stay in the trial, the longer you get a low LDL, the better the reduction in the risk that you can achieve. Next slide. So management is dyslipidemia high on priority, and statins we all know are the first line agents. But the concerns that we have with statins are, do all statin users achieve the LDL cholesterol goals that we need as per the guideline recommendation, which is over a period of time become more and more stringent. The present high risk category is almost less than 50. And the concern too is how to achieve LDL cholesterol target after maximally tolerated dose of statin. And some patients may not tolerate any dosage, so how to achieve? So let us look at the first concern. So look at 2016 versus 2019 guidelines. If you look at the LDL in low risk, it has remained the same. But when we come to very high risk, the numbers have come down drastically. In high risk, previous target was less than 100, and the present target is less than 70 as per the 2019 guidelines. And when you consider very, very high risk group, the target is even more stiffer, less than 55. Next slide. Based on revised ESC 2009 guidelines, how many patients do we think have controlled LDL cholesterol? So a cross-sectional study was done, and it was an observational study, and basically they looked at lipid modifying therapy in both primary and secondary care, and this was called as a Da Vinci study. And the number of patients were about 6,000, divided between primary and secondary arm. And the objective of the trial was to evaluate the impact of ESC dyslipidemia management guideline on the goal achievement. Next slide. So proportion of patients achieving goal, basically if you look at it, overall it is about 51%. 27.6% did not achieve the goal, and 9.2 were not achieving the goal. So 27.6% were receiving high intensity statins. 30% of the patients achieved goals with high intensity statins. So that is how it is. And 37.5% eligible were receiving high intensity statins as per the 2019 guidelines, and only 22% achieved the lipid goal with the even with high intensity statin. So we know that there is a large gap in this. So hence that gap needs to be addressed. Second concern was how to achieve LDL cholesterol after the maximally tolerated statin. The management dyslipidemia is high on priority. And if you see a ASCVD, basically all ASCVD check the baseline LDL cholesterol levels. ASCVD with ACS, stroke, or peripheral arterial disease. So basically 85%, and complete statin intolerance is there in about 40% of the patients. And in that patients, how to manage them and what is the kind of incidences. So let's look at it in the next slide. So this is an observational study of 23,000 patients post-ACS who are prescribed high-intensity statin. And if you see that the adherence to high-intensity statin keeps coming down with time, and 66.4% of the patients present did not take high-intensity statin at the time of discharge, and only more than 50% had drug interruption within the first month, and non-adherence to high-intensity statin was associated with a strong association with a high mortality of more than 16% with a p-value of less than 0.001. So with this, we have the ACL inhibitor, ATP citrate lyase inhibitor. It is a first-in-class molecule, and it is a very useful lipid lowering, LDL lowering drug. It was approved in USA, European Union, and India, and the approval in USA and European Union was in 2020. What it does is basically reduces uncontrolled LDL cholesterol. It can be used in conjunction with the maximally tolerated statin in mixed dyslipidemia, familial hypercholesterolemia, high risk of ASCVD. And patients with statin intolerance and in whom statin is contraindicated, it can be used in those indications. Next slide. So what bempedoic acid does is basically, you can see here, it acts on this muscle. It doesn't act on the skeletal muscle. It only acts on the liver enzyme, ACS-VL1 enzyme in the liver, but does not act on the skeletal muscle. Hence, it doesn't have the skeletal side effects. Hence, it has only a purely systemic effect of reducing the circulating LDL cholesterol, and it can have a slight increase in the uric acid and creatinine, but that is only a chemical change. It is not that the patient has any kidney failure. Next slide. So management of patients using bempedoic acid. So half-life of the, so something about the drug. Half-life is about 21 hours. Elimination is 70% excretion through kidney. 5% through feces, and less than 2% unchanged drug through the kidney. And when we look at renal impairment, no dosage adjustment is necessary. Though it is not studied in a ESRD, more trials may be underway. When we look at hepatic impairment, no dosage adjustment. So whether it is a renal impairment or hepatic impairment, you don't need any dosage adjustments. So all patients, we should assess the uric acid when clinically indicated. We should look at if the patient has a prior history of gout, because this can increase the uric acid, and make sure the uric acid is well controlled. Patients who are more than 60 years of age and who are taking concomitant corticosteroids, either for their joint pains or for any other things, or if they have any systemic indication for steroids, we should keep a watch on such patients. Patients discontinue is when patients are more than 80 years of age, and total dose is more than 20 milligram or more than 40 milligram of pravastatin. And prasugrel, discontinue bempedoic acid, and breastfeeding, it is not yet approved. Next slide. So this is the CLEAR outcomes trial, basically cholesterol lowering bempedoic acid ACL inhibition regimen. And this was published in the New England Journal of Medicine. And they used, the study investigators used bempedoic acid. So it was a global cardiovascular outcome-based trial, study of bempedoic acid in statin intolerant patients with elevated LDL cholesterol. So primary and secondary prevention patients with elevated LDL cholesterol and statin intolerance were selected. Visit 1, statin intolerant patients were screened, and in visit 2, 4-week run-in period was done. And visit T1, they were randomized to either bempedoic acid 180 milligram per day for 7,000 patients or placebo in 7,000 patients. And study completion, 1,620 primary 4-component MACE was the endpoint that was defined. And a median follow-up of 40.6 months was achieved in about 14,000, close to about 14,000 patients. The primary endpoint were cardiovascular death, non-fatal MI, non-fatal stroke, or coronary revascularization. A minimum of 1620 primary events were expected over a period of 2 years. Next slide. So statin intolerance, bempedoic acid, and we all know that it is useful in such patients, but we didn't have the cardiovascular outcomes which were not assessed. Hence, this is a very important trial in that regard. So primary 4-point MACE, that is non-fatal MI, non-fatal stroke, coronary revascularization, and cardiovascular death were selected as a primary endpoint. There were few key secondary endpoint. One is the 3-point MACE, which include MI, stroke, or CV death, fatal or non-fatal MI, coronary revascularization, fatal non-fatal stroke, cardiovascular death, and all-cause mortality. They were all hierarchical secondary endpoint. So you start from the basic 3-point to move on to the further things. So that's a busy slide. You can look at the median age. Median age was 65 in both the arms. BMI was also similar in both the arms. LDL cholesterol at baseline was similar in both the arms. HSCRP was similar. GFR was also similar. And when we look at cardiovascular risk category, primary prevention were comprised about 30% of the patients, and secondary prevention was about 70%, out of which CAD was the predominant secondary prevention group. And glycemic status was known, and it was about 45% diabetics. And out of that, 19% were inadequately controlled. Statin use was in 22%. Histamine use was in 11%. Next slide. So this is the baseline data. And if you look at the 4-component MACE, compared to placebo, bempedoic acid did much better with a relative risk reduction of 13%, 3-point MACE 15%, fatal non-fatal MI 23%. And when we look at revascularization, 19% reduction. So in all the primary and the secondary endpoints, bempedoic fired better as opposed to placebo with a significant p-value. Next slide. So among statin intolerant patients, treatment with bempedoic acid was associated with a lower risk of 4-component MACE, lower risk of 3-component MACE, lower risk of MI, and a lower risk of coronary revascularization. So all the 4 goals of therapy were achieved with bempedoic acid, what we always desire from a statin. Next slide. LDL cholesterol and hsCRP reduction. So let us look at how that has fared. You can see there is a significant 22% reduction in the LDL cholesterol in the bempedoic acid. And that reduction was sustained till the end of the trial. Next slide. So when we look at adverse effects, you look at serious adverse effects, it was similar in both bempedoic and placebo. Myalgias were similar in both the groups. Discontinuation due to myalgia was similar. Renal impairment slightly on the higher side. Change from baseline creatinine level after 6 months, 0.05 as opposed to 0.01. And hyperuricemia percentage was 10.9. Gout percentage was 3.1. So these are the 2 parameters that we need to watch for: the creatinine level and the uric acid. And change from baseline uric acid level was also significant in bempedoic acid arm as opposed to the placebo arm. Next slide. So bempedoic acid becomes the first ACL inhibitor and first oral non-statin to demonstrate statistically significant reduction of MACE events in all 4 event group. And this is one of the first drugs after statin to show this benefit, because if you look at fibrates, niacin, all of them did not show this benefit which bempedoic acid has been able to show. So in conclusion, bempedoic acid is an effective alternative for statin intolerant patients, and it is well tolerated. It has significant reduction in both LDL cholesterol and hsCRP. It has significant benefits as far as the primary and the secondary endpoint goes. And it is one of the important effective approaches to reduce major events. Next slide. With this, I would like to thank you all for the patient hearing about the CLEAR Outcomes trial and how bempedoic acid has shown benefit in this group of patients. Yeah.
Thank you so much, sir, for giving such a interactive session, and would like to thank you for giving such a lucid presentation. So it was up to the point. So there are few questions in online I have, so I'll just check it. There are a few questions which have come. So before, you talked about 2019 guidelines becoming stricter and stricter every day. So what you target in your day-to-day practice? What LDL cholesterol goal you target? And is there any chances of neurological complications which may arise because of that?
Yeah, it's a very, very important question. So basically it depends on the type of patient. So if my patient is primary prevention, then I target somewhere close to less than 100. Whereas it is secondary prevention, 1 event or a revascularization, I try to target less than 70. But if there is a repeated event, then I target less than 50. So depending on the type of, or if he has multi-regional disease, like if he has coronary along with peripheral or along with carotid, then I target the more aggressive less than 50.
Thank you so much, sir. Talking about next, I have a patient with diabetes, hypertension, and statin. I am able to control LDL cholesterol up to 100 milligram per deciliter, but should I add a Bemdac to it? That is what the question is.
Yeah. So I think considering that he's a gentleman with diabetes and hypertension, and LDL is only about 100, I think adding a bempedoic acid will be beneficial to bring it down to 70, because you know that diabetics are at a much higher risk, so compared to the normal population. And in addition to the diabetes, he also has hypertension. And I don't know whether he has smoking and other risk factors. And what it is, carotid Doppler and the calcium score. So I think adding a carotid Doppler and calcium score as far as the investigation goes, and as far as the treatment goes, targeting 70 by adding a bempedoic acid will be useful in this patient.
Thank you so much, sir. Next question is about they are asking about patient is already on high intensity statin, but whether should I go directly for PCSK9, which is a costly affair. But if I talk about ezetimibe, is ezetimibe adding ezetimibe is the first option, or should I add bempedoic acid ezetimibe directly to these patients?
Yeah. So it's a very interesting patient. So it's a very high risk patient with a very high LDL cholesterol, which is not controlled by high intensity statin. So I think it's a very interesting patient. So I think as far as the outcomes go, outcomes are more in favor of PCSK9 and bempedoic acid. Ezetimibe has not shown any outcome-based CVOT outcome-based benefit. So we have a patient here who is at high risk, and who needs an outcome based benefit. So I think we should, and probably he has a familial dyslipidemia, because on high intensity statin, if he is not controlled, probably he has a familial dyslipidemia. So I think you should choose between a PCSK9 and bempedoic acid rather than a ezetimibe. And depending on the cost economics, I think you can take a decision. Adding a bempedoic acid will be much more easier, and then you can look at how he does over the next 4 weeks. If it is still high, then you can probably add a PCSK9. So that's what we can do.
Okay, sir.
If you, yeah.
In diabetes patient, is it beneficial to give bempedoic acid? Because there is a data which has been shown that it improves. There's less reduction or less.
So it all depends on what your LDL cholesterol is. If your LDL cholesterol is not meeting the target with your statin therapy, tolerated statin therapy by the patient, then it may be worthwhile adding the bempedoic acid.
Is it safe in CKD patients? Or?
So it has not been studied in ESRD, but otherwise it is safe in CKD patients.
So how do you define, this is my personal question, how do you define statin intolerance in your day-to-day practice? And
yeah, so basically true statin intolerance is a very uncommon thing. We see in about 5% of the patients true statin intolerance, in the sense that the moment you start statin, they start developing various symptoms ranging from myalgia, severe fatigue, severe. So I have quite a few of those patients. So it's like about 4 to 5%. So true statin intolerance. But much more common is a relative statin intolerance, in the sense that you give them 20 milligram, they tolerate. When you go for a high dose, high intensity statin, like 40 milligram of rosuvastatin or 80 milligram of atorvastatin, that's when they start developing the statin intolerance symptoms. So this is not a true statin intolerance, but a high dose statin intolerance. So in such patients, what you can do now, previously we didn't have options, but we probably added ezetimibe in such patients. But now we have an outcome-based drug, that is bempedoic acid. So you cut back on the statin to the previously tolerated dose and then add a bempedoic acid. So if the patient has tolerated 20, you go back to 20 and add bempedoic acid.
Yes, sir. Next question from my side is, if we are talking about, of course, bempedoic acid, we have been talking about CVOT trial, but there's always a said that it is an add-on therapy. So without because as per the guidelines, it is an add-on therapy to statin treatment. So can we give it
Except in statin,
individually?
totally true, basically true intolerant statin patients, then it can be a primary therapy.
Yes.
If the patient is tolerating statin, then it becomes an add-on therapy.
So nowadays it has been discussed about that International Lipid Expert Panel has discussed that bempedoic acid can be added before PCSK9. So
Yeah.
how do you see the future of bempedoic acid from your in clinic perspective point of view?
Yeah, if you look at our patients, almost if you look at the lipid levels of our patients that follow, almost like if you say about 40 to 50% of the patients are not achieving their LDL targets. Even if you look at the Indian targets, the Indian Lipid Association targets, they are also quite stiff. They are also less than 50 because
Yes.
we have a much earlier CAD and much more diffuse CAD and much more extensive CAD as opposed to the Western. So it makes much more important in our population because when we look at the levels, at least in our day-to-day OPD practice, almost 40 to 50% of our patients are not achieving the target LDL, and in them adding a bempedoic acid has found to be useful for us.
Yes, a lot has been discussed about LDL cholesterol being a center point in dyslipidemia management, and there's a different aspect about triglycerides. So, of course,
Right.
uh, we have to take both of them. Where do you prefer? Which element do you prefer, LDL cholesterol or triglycerides?
So always the primary target is always LDL as far as the ischemic heart disease is concerned. Uh, Triglyceride are all secondary targets. Uh, Primary target always is LDL, then non HDL, and then HDL, and then triglycerides. So in that order, we target our uh, lipid lowering in our patients.
Thank you so much, sir. This was such a nice presentation, and we are very thankful on this evening that you have given us your important time. Of course, we started late, but it was a really interactive session, and your in-clinic expertise and experience will definitely help us in the management of dyslipidemia. Bempedoic acid has, of course, given us a hope and another choice in the management of dyslipidemia. And thank you so much, audience and all the delegates who have actively participated in this clear talk. And sir has already cleared all our doubts on uh, bempedoic acid clear outcomes trial. So thank you so much, sir. And
Thank you all.
good
Thank you all.
evening, good night, all the delegates. Stay safe, stay and take care of yourself. Thank you so much. Thank you.